Good morning. I'm Dr. Paul Annett, a sports physician practicing out of the Hurstville rooms and also down in the Sutherland Shire. I'm sorry I can't be with you in person today, but unfortunately I have to be at a conference in Adelaide, so I'll be presenting this talk via the wonders of modern technology. The topic I'd like to present today is imaging in musculoskeletal medicine. I know as physiotherapists you may not be formally trained in imaging in musculoskeletal medicine, but often are called upon by your patients to make decisions in this area. I hope this talk can give you a framework to guide you through some of the decision-making processes based on my many years of experience in this field, observing not only the good, but the bad and the frankly unnecessary. As a basic premise, many of the tests we perform are unnecessary, and they offer little over and above a good, thorough clinical evaluation. I'll present my principles on when to get imaging later on, other than to say it's very important that the test will influence or change your management. There may be costs to the patients, not only financially, they may actually have to pay for the test, it may not be covered under Medicare, but also personal costs of having to take time away from their day and work to present for a test which may not be required. Investigations are not necessarily benign. Certainly radiation dose with any X-ray, and consider the significant radiation dose of a lumbar spine CT scan, and also what I describe as the medical merry-go-round. Uncertainty in diagnosis leads to incorrect imaging, which may lead to incorrect interventional treatment as the initial clinical assessment was not correct and the imaging was misleading. I'll present a case of this later on. From a public health point of view, we must think about the millions and millions of dollars that are pushed into imaging every year, and in a lot of cases the imaging is not required. And also we must also consider the very large corporate investment in imaging companies, and they obviously need to make a return on their investment. So when is it appropriate to image? In a chronic condition, persistent symptoms for more than 4 to 6 weeks that have involved appropriate initial conservative care with rest, activity modification, appropriate physiotherapy with the rehabilitation program, and the use of medications including anti-inflammatory drugs, this would seem quite appropriate. Concerning features on history, particularly initial traumatic injury, a plain X-ray would be mandatory, and also severe or persistent pain and systemic symptoms such as weight loss, fever, or other red flags. A past history of carcinoma is very important, and the main ones we consider are breast, prostate, and melanoma. Lastly, any concerning features on physical examination. This may include loss of joint motion, bony tenderness, or a joint effusion. So what are some of my general principles of ordering imaging in patients? And I'll present 3 today. The first one is the investigation should change or influence your management. Any test you perform needs to be acted on and needs to change the way that you will ultimately deliver care to that patient. If someone presents with lateral elbow pain, which is obviously tennis elbow clinically, ordering an ultrasound really won't change your initial treatment of relative rest, physiotherapy, and a rehabilitation program. The investigation should be the most appropriate one to confirm the problem based on your clinical presentation. So a thorough and accurate history and examination to come up with the most likely working diagnosis, and then you obtain the imaging which will best support your hypothesis. In many cases, this may just be a plain X-ray. Sometimes it may require more high-powered imaging, such as an MRI scan. But it needs to confirm what your initial suspicions are and to help with the management of that patient. Lastly, the investigation should be the simplest and cheapest one to confirm the clinical suspicion. Nowadays, every patient turns up wanting to obtain an MRI scan of every injury, and it may be in a 70-year-old fellow who has developed knee pain for the last 3 months that a plain X-ray is the most appropriate initial investigation because the likely diagnosis will be osteoarthritis of his knee. I'll now discuss each individual modality, including their strengths and weakness, which, as I'm sure you're all aware, includes X-ray, ultrasound, MRI scanning, CT scanning, and nuclear medicine or bone scanning. So X-ray, the humble X-ray, which is often forgotten in the high-powered world of musculoskeletal medicine. In my opinion, there is never a reason not to order a plain X-ray if a patient presents to you with pain, which has been going on for any period of time. An X-ray provides useful clinical information even if it's completely normal. Most notably, it excludes nasty pathology, including tumours. It may demonstrate missed fractures. It certainly can demonstrate osteoarthritic change in a joint, and you have the ability to look at joint stability with stress or weight-bearing views. The first case I'd like to present is a 55-year-old fellow. He's had 6 months of anterior groin pain, which has been treated by his therapist as hip flexor tightness or tendinitis, but it does not seem to be improving with current conservative care. He's referred back to his GP, who performs an ultrasound, which demonstrates a direct inguinal hernia. On examination, he has restricted hip motion, particularly into internal rotation and into flexion, with pain in these positions. There are no physical hernias on palpation. Based on the patient's ultrasound, a hernia repair was performed, but unfortunately this did not resolve his symptoms. Subsequent review and based on the clinical presentation led to performance of a plain X-ray, which showed quite advanced osteoarthritic change in his left hip. The patient was subsequently given a total hip replacement, which completely resolved his symptoms. This is unfortunately a story that I've heard many times over the years. The next case is another patient whose care I was involved in. He'd had 3 months of increasing lower back pain and had had 5 sessions of chiropractic therapy without improving his symptoms, but no imaging had been organised. Medically, he did have a past history of melanoma. Unfortunately, subsequent X-rays did describe some sclerosis and collapse of the L5 vertebra, and ultimately this patient had secondary melanoma in his spine confirmed on an MRI scan, but did very well with medical management. So ultrasound, where do we start? There is no doubt that ultrasound is a grossly overused modality, especially by the general practitioners, where often it does appear to be used in making a diagnosis, rather than confirming a diagnosis, which may be problematic, especially in the shoulder, where the scan is quite often misleading. An ultrasound really should be no more than an adjunct or extension to a good clinical examination and may have some role in helping to confirm a clinical suspicion. It is important to note that as soft tissue and tendons age, as you all know, there may be normal age-related changes, including the finding of hypoechoic or what's described as partial tears. In many cases, these may simply be normal age-related changes and not symptomatic, again taking us back to the importance of a good clinical assessment. Ultrasound has nowhere near the accuracy in comparison to MRI scanning. A good study from Prince of Wales a few years ago looking at rotator cuff tears showed that ultrasound had around a 60% accuracy compared to MRI scan. Ultrasound can also be extremely dependent on the sonographer, the radiologist reporting, and even the department that is doing the films and the quality of their equipment. There are all variations in ultrasound quality. One advantage of ultrasound may be that it can assess tissue as a real-time assessment and is one of the few modalities that has this technical possibility. As another clinical guideline, I would suggest that no ultrasound should be performed without an accompanying X-ray at the same time. I see numerous patients, particularly with shoulder pathology, presenting with an ultrasound without a plain X-ray, which will often be important in helping us make a correct diagnosis. The next case I'll present is unfortunately a story that I hear far too often in my practice. A 55-year-old lady who presents with a 4-month history of increasing shoulder pain without precipitant. She was referred by her GP for an ultrasound, suggesting a subacromial bursitis, and the radiologist suggested performing an ultrasound-guided subacromial bursal cortisone injection, despite never having seen the patient, taken a history, or examined them. As may be expected, the subacromial cortisone injection gave the patient little improvement, and they came to see you with ongoing shoulder pain. The examination findings clearly showed a global restriction in shoulder motion, both actively and passively, with excellent rotator cuff strength and without pain. The clinical examination, as demonstrated by this picture, would be most consistent in this age bracket as an adhesive capsulitis and not a subacromial bursitis. Unfortunately, the ultrasound was performed without a plain X-ray, and it must always be considered that the underlying glenohumeral osteoarthritis is present, and the patient was sent for a plain X-ray, which unfortunately did demonstrate this abnormality. The other pitfalls I see with ultrasound, the first one is using ultrasound to diagnose an Achilles tendon rupture. An Achilles tendon rupture is a clinical diagnosis diagnosed by the appearance seen on the screen here and also a positive Thompson's test, squeezing the calf with a lack of foot plantar flexion. Ultrasound is often misleading, often calling the injury a partial tear. The other pitfall is ultrasound in the knee, again a favoured modality from a lot of general practitioners. Unfortunately, an ultrasound of the knee really provides little further useful information than a solid clinical examination. The main conditions that may be diagnosed include an effusion in the knee, obviously done well with a clinical evaluation, a Baker's cyst, which often provides little or no clinical relevance, or potentially an acute medial ligament injury, again much better diagnosed clinically. The main role of CT scanning is in the assessment of bony structures. It really has little application in the assessment of a soft tissue injury. It is most helpful in looking at missed or subtle fractures and as an extension of a plain X-ray. The main downside with CT scanning is its high radiation dose, especially when it's used in the axial part of the skeleton. It is clear that CT scanning, as it currently stands, is vastly overused in the management of non-radicular back pain, predominantly by general practitioners. The next patient I'd like to present is a 7-year-old fellow who presents with a 3-month history of not only lower back, but significant radicular-sounding left leg pain. He has had a CT scan performed, which showed generalised spondylitic change with multi-level disc prolapse, but no obvious neural compromise. His clinical examination demonstrated a strongly positive slump and straight leg raise test. His neurological assessment was normal. As is often the case, the CT scan pictures were a little indiscriminate or unclear, and a subsequent MRI scan was ordered based on the clinical suspicion of a nerve root compression. This demonstrates quite nicely a synovial cyst coming from the facet joint, clearly impacting the nerve root. As a modality, bone scanning definitely has its place in musculoskeletal assessment. The main advantage of bone scanning is its sensitivity. As a general rule, if a bone scan is negative, then it will exclude any significant or serious pathology. Its main downside is that it is not always a specific test, and I remember one specialist describing it as unclear medicine. It's very good, and at least as accurate as MRI scan, for assessing both missed and stressed fractures. And its other main advantage is being able to assess the whole body at the same time, which can be useful with patients presenting with multi-site pathology. One of the main applications that I use bone scanning for is for localising specific pathology in areas of multi-site degeneration. I'll provide an example of this in the next slide. This case is a 75-year-old fellow who presents with a 6-month history of unilateral left-sided neck pain, which is causing him a lot of difficulty when trying to drive his car and look over his shoulder. An MRI scan was consistent with generalised multi-level spondylitic change, but without obvious localising features. A subsequent regional bone scan of the cervical spine with SPECT fusion views clearly demonstrated a very hot facet joint, which was successfully treated with a CT-guided cortisone injection with resolution of his symptoms. I've saved the best for last with MRI scanning, which really is the gold standard of imaging, and as my radiologist friend Faisal Rashid likes to call it, the test of truth. There really is little of significance that will get past the MRI scanner. But like any imaging modality, interpretation of the pictures is essential, both from the point of view of the radiologist and also the treating practitioner. It would be reasonable to suggest that most MRI scans of a 65-year-old shoulder will demonstrate multiple sources of pathology, including partial thickness rotator cuff tears, AC joint osteoarthritic change, and slap or labral tears. And it is up to us as the practitioners to determine which of these is the likely source of the patient's symptoms. MRI scanning is excellent for soft tissue assessment, as we all know, but is a lot weaker than CT scan for fractures. But one advantage is that it can show bone marrow edema, bone bruising, or a subclinical fracture. At this point in time, the main downside for MRI scan is its cost. And as I mentioned earlier in the talk, that's cost not only to us through Medicare, and also cost to the patient, as it's uncommon now for MRI scans to be bulk billed, and also their time and effort to go for the investigation. It will be great to be able to organise an MRI scan on every patient you see, but this is obviously unrealistic, and patient selection for the right investigation, as I've mentioned throughout this talk, is really of paramount importance. So what are my take-home messages with regards to issues in musculoskeletal imaging? The first is imaging without a good clinical assessment with both history and examination. It's very difficult to order an appropriate test if you're unsure what condition that you're looking for. The second is relying on imaging to make a diagnosis. The diagnosis should be largely made on history and examination and then supported by the imaging, but not necessarily made by it. The third is the continued use of ultrasound without ordering a plain X-ray, which should be mandatory when all ultrasounds are ordered. And the fourth is the overuse of ultrasound and also the underuse of plain X-ray. Lastly, where at all possible, we should be encouraged to try and reduce the use of CT scanning in non-radicular lower back pain. Thank you for your time this morning and listening to this presentation. I hope it does provide you with some guidelines and framework when you're considering ordering investigations for your patients in the future. All the best.